For the very last presentation, then we have some live demo or on table or on patients. So we try to keep interactive, just too little information, let's say piece of information. The very first, I don't know when and how it could happen, but there is a chance that there may be a kind of, let's call it a stage in my town for to go, I mean, a little bit into depth of these topics. I don't know if many STD, whatever is the future organization, there could be that opportunity. So you have to keep in touch with this organization to see if we can have a kind of a more even interactive and practical theoretical workshop in my town, where I have a kind of educational center and I receive some doctors who work with me a little bit. That's it. And second, please ask me whatever you want, because I know that many of you came after to talk to me and ask this and that, but please ask me whenever you want. You interrupt me because that's the very last presentation, and then we have live demo. So we speak about complications. Complications of foam sclerotherapy and of sclerotherapy in general typically are general kind, and you can read here they are typical of liquid sclerotherapy and foam sclerotherapy. We will discuss a little bit of them. And there may be some possibly related to sclerosant foam air gas complication, which means foam may have some additional complications, as we will see, neurological or pulmonary and so on and so on. Let's go step by step. I will present some data and evidence from a few publications, such as this very excellent one, a little bit old, from NICE, National Institute for Health and Clinical Excellence in UK. I don't know, Richard, if they updated this publication, because NICE usually updates. If you can check for me, please.
Yeah, I think it's
they usually update.
2013, I think it was updated.
They update the foam sclerotherapy complication review and so on. Well, you can check. You can check whenever. And this is one part of my presentation. Then we published with Kurosh Parsi an article on foam sclerotherapy complications in 2012. And these are the guidelines, European guidelines, where again you can find a lot of information concerning the possible complications. So let's start from allergy. Allergy can be of anaphylaxis nature or anaphylactoid nature. So can be local or generalized complication. Here we have dermatologists who know more than me, so I will be very silent. Anyway, if it is a systemic involvement, it is much, much rarer. This is for sure. On the contrary, some urticaria, some bulle are possible during sclerotherapy, and as a matter of fact, foamed sclerosants are associated with a lower incidence of any form of allergic reactions. Of course, you would say, if you are allergic to a substance, it does not depend on those. Well, that's not completely true, because anyway, those may play a role. And we know that foam is made of 1 part of liquid, 4 parts of gas. So that may help, let's say, to reduce a little bit also this problem. Let's focus now on a much more important issue, which is DVT, deep vein thrombosis. As you will read in my slides, reliable data are not always available. Here, for example, how much is the incidence? We don't know. We don't know, because it depends on how you investigate your patients, first of all, because a number of procedures could be silent. I mean, little peroneal thrombosis or little, let's say, tibial thrombosis could be silent. Soleal thrombosis could be silent as well. And the vast majority of the DVT were and are in the lower leg, not in the thigh or femoropopliteal, let's say. So it is called distal deep vein thrombosis. As you look at this kind of analysis of statistical reports, basically we are around 1%, let's say. Again, it depends on the technique, on the sclerosis, on the dose. So there are several factors which seem to affect. And let's say that probably the dose is one of the most important factors which may affect the incidence of DVT. For example, in this study, Ken Myers demonstrated that you can reduce the DVT rate if you stay below 10 milliliter of foam. True or not, this was a study which clearly indicated not to overcome, let's say, 15 milliliter whenever possible. If we talk about pulmonary embolism, then we will go back to DVT because of thrombophilia and so on. If we talk about pulmonary embolism, we have even fewer reports. For example, in this case, Gillet from France reported one case out of 1,025 patients treated. And that means probably, let's say, 8,000 sessions or 7,000 sessions. So at the end of the day, we have no reliable data because we have a lot of silent pulmonary embolism, as everybody knows. Anyway, it could be of thrombotic origin, it could be of gas origin. I would stress the point of cough. Cough immediately, I mean 1 minute, 2 minutes after foam sclerotherapy is somehow considered an irritation, let's say, which could be based on gas and or on chemical activity. I would say much more gas because it happens often when you immediately change your position after foam and so on and so on. So coughing, if you leave the patient immobile, is reduced in terms of incidence. Superficial venous thrombosis, even more chaos. Why? Because we go from 0% to 45.8, which is ridiculous in my humble opinion. Because when they speak about 45% superficial venous thrombosis after foam sclerotherapy, they certainly include the results, which is a chemical phlebitis. So we should mean superficial venous thrombosis when the inflammatory component comes out, not just when the vein is a little bit tender and a little bit painful. Anyway, in NICE assessment, the review I showed you before, they basically had a median incidence of 4.4%, which is quite reliable, let's say. So it could extend to deep venous system, and it could become a DVT, we know it, and it may also occur weeks after foam sclerotherapy. So let's come now to what we could do. First of all, we should stress the point of thrombophilia. I mean, whenever we perform sclerotherapy, even more foam sclerotherapy, we should talk to the patient to know if there is any thromboembolic antecedent, to know if there was any strange pulmonary embolism in the family, stroke, whatever, because that can help us to understand more. I just give you an example. If the patient had a DVT and wants to be treated for varicose veins, you should ask yourself, why did he get DVT? Is it unprovoked? Is it provoked? Could he or she have a thrombophilia? So I love to screen for thrombophilia in all patients when you get some suspicion of thrombophilia. It means previous DVT, where you don't know exactly which was the reason, and let's say strange stroke or whatsoever. Again, do not use large volume of foam. We know that stockings is a prevention of DVT, so we should always use stocking after sclerotherapy, also on this kind of based on this kind of recommendation. And at the end of the day, decide on a case-by-case basis, so to perform a benefit-risk assessment for that specific patient and indication. Okay, one thing only. When we speak about thrombophilia, we should keep in mind that not all thrombophilias are the same. We will come back to this. Neurological events. Okay. Neurological events, it's really, really difficult to know how much is the incidence once more. The vast majority of the doctors will tell you 0. because I never got, they say, I never got a cerebral neurological events. Are scotomas a neurological events? Visual disturbances are a neurological events. They are part of migraine with aura. When you have migraine with aura, it could be not exactly a TIA, of course, but it could be something different based on spasm and so on and so on. Whenever you get a clear cerebral event, then you have to screen for patent foramen ovale, because that's the only issue. We know about this story, probably you read a long time ago, and we immediately wrote to the Journal of Vascular Surgery to clarify that this was a wrong procedure. A lot of polydocanol foam was injected in this patient. So somehow, apart from the patent foramen ovale, the stroke after varicose vein foam injection sclerotherapy is an issue, but should not, let's say, overemphasized. Let's have a look. Patent foramen ovale is present probably in 25 to 30% of the general population. So it means here there are some, say, 7, 8, 10 people who have it, okay? In the vast majority of the cases, we are talking about a very, very small hole between the right and the left heart. You see, it is written, let's say, 27.6 in this kind of report. If you look at Mayo Clinic study, the 27.3 in this case, again, the mean diameter at the autopsy, not clinically relevant, is 4.9. But if you look at here, when you start to get symptoms, for example, we talk about paradoxical embolism, the mean diameter is 1 centimeter. That starts to be a relevant hole, 1 centimeter. When you get the typical paradoxical embolism, stroke, TIA, in a young person, you have to think about PFO. Always you have to think, apart from thrombophilia vasculitis. So what could we do, basically? We know that echocardiography is used, but we also know that it's not probably the only method, and we will see in a second. And again, you need Valsalva maneuver to understand better, because Valsalva maneuver dilate the PFO, becoming nearly double. So how could we know that one person has a PFO? I would personally recommend transcranial color duplex ultrasound. Alternatively, transcranial Doppler ultrasound. Why? Because we may detect hits, high intensity transient signals, which are in the middle cerebral artery, and they are visible on the Doppler, let's say Doppler spectrum has spikes, okay? And you can do it very easily from the temporal area through a color duplex or through a Doppler probe. But you need a kind of contrast agent which is represented by saline solution, blood and air mixed together, put inside, and then if you get any cerebral artery hits, then you know that there is a passage from right to left. This is very simple to do. Alternatively, you should do the classical transesophageal echocardiography, which is complex and which requires anyway a contrast agent as well. So that's another contrast agent, let's say, and it's not so easy to perform. So personally, I always send my patient to the neurologist or to the specialist who performs the let's say, Doppler or color ultrasound duplex investigation in the middle cerebral artery. Whenever we talk to the patients to decrease this likelihood of cerebral events, we have to ask about migraine, but especially migraine with aura. Migraine with aura can be connected to a patent foramen ovale. It is quite well established, let's say. Much more if you have, let's say, a cryptogenic cerebral ischemia without atrial fibrillation or any other thrombophilia vasculitis. Whenever you get a stroke or a TIA, when you are 20, 25, 15, 30, it's not carotid problem, we know that, apart from very selective cases. So it could be a patent foramen ovale. So migraine with aura and any specific cerebral event should alert us before we take a decision. Then, if you know something strange, or if you want to reduce anyway the possibility of getting a cerebral event, please keep the patient immobile. Because the patient immobile means a lower passage of bubbles into the deep circulation, and especially lower in terms of bubbles per time. The problem is not the bubbles which go into the deep veins, they always go. The problem is the patient should not get a bolus of bubble all at once, because that bolus arrives in the cerebral circulation in case of patent foramen ovale, which is not very nice, let's say. Valsalva is typical maneuver to elicit a bolus. So never perform Valsalva. I love immobilization, and I prefer no compression for a few minutes after the procedure. Here you see, for example, how foam can arrive from right to left when you have, and these are the spikes, I mean the hits I told you on the middle cerebral artery. Again, when we have visual disturbances, is this a TIA or is this a spasm, a chemical irritation? As everybody knows, we know people that have migraine with visual disturbances, with aura, just because they eat something wrong. So that's chemically induced. So it's not a TIA. So that's the issue, because many reports are strange. They speak about TIA because of foam in case of migraine, probably. Someone such as Frullini, you told about that, spoke about endothelin. I would speak about histamine and other endothelial mediators which are released during any inflammation, such as sclerotherapy. They may be vasoconstrictors. What we know is that with CO2 or CO2 plus O2, we reduce the visual disturbances. This is what we know from literature. How much is the incidence of visual disturbances after foam sclerotherapy? Well, again, up to 14%, but in NICE it was 1.4, which is, again, quite reliable. This is the study from Frullini and the endothelin. If we talk about TIA and stroke, it's difficult to say about incidence, because it's really, really difficult about TIA and stroke. Let's tell that it is important, of course. It happens after liquid as well. This is important to remember. It happens after liquid as well, not only after foam. And in the vast majority of the patients, they had a complete recovery, because it is mostly a transient ischemia. This is very important to keep in mind. If you get, it is extremely rare, a TIA or even a stroke after 10 minutes, 5 minutes, 15 minutes, you have to think about gas. This is a gas embolism. If you get a TIA or a stroke after a few days, it's more probably clot. So it's a little bit more serious, let's say, okay? So if it is immediate or nearly immediate after foam, oxygen, immediately oxygen to the patient, okay, till down the head and so on and so on. And it is gas, so if it is unfortunately air, we know that nitrogen will need more time. If it is CO2, O2, which is rarer, anyway, it will be quicker recovery because it will be so diffusible. Let's keep in mind that CO2 is 50 times more diffusible than a nitrogen. So in the bubble, it will go out of the envelope very quickly because it has a very relevant diffusibility. Whenever you get TIA and stroke, the right to left shunt, and in particular PFO, was the most consistent risk factor. This is as to literature, okay? Again, higher volumes of sclerosant and sclerosant foam could be a little bit more linked to possible, again, I'm trying to give you data, but it's not so consistent, to possible complication. Again, we can use some measures, but we have no validation at the moment. In this study from Nick Morrison, you see, using CO2O2 foam, basically you get fewer side effects, especially as to visual disturbances. So it could somehow be involved also for the gas component. I showed you before the difference between biocompatible gases and air. Okay, I would go on. Okay, anyway, let's keep in mind what I told you before. Luckily, from the chemical point of view, CREF is our enemy, CREF is our friend, because CREF neutralizes the chemical action at distance. It's impossible to suppose that in my brain or in my lung I get a chemical action because of foam. It's nearly impossible to think about that. Okay, I cannot assure you this, but the evidence is that probably binding sclerosant to protein to red cell neutralize the chemical activity. It's possible a gas activity, it's possible a clot activity, but not a chemical activity at distance. That's because of many studies, and you see here a few studies from Kurosh Parsi, which I reported about before. And again, Mike Watkins and again Lorenzo Tessari, as I told you. Another possible complication, tissue necrosis. Tissue necrosis may happen. We should distinguish which necrosis, of course. Anyway, first possibility, extravasation. Okay, extravasation, if you extravasate a high concentration liquid or a high concentration foam, you get some necrosis. But if you extravasate foam, you extravasate much less liquid than air. So extravasation necrosis because of foam is less probable because of this air or gas component. Not only extravasation, but also other possible causes are called in, let's say, as a possible reason. Arterial occlusion, because you inject an artery. Okay, veno-arterial reflex vasospasm. This is important because we have a sphincter between the venular and the arteriolar side, and sometimes this sphincter goes into spasm because of a possible excessive pressure or dose or whatsoever. Last but not least, this is common in dermatology, embolia cutis medicamentosa. What is it? Somehow you get a kind of bolus of drug which goes in periphery, passing, and this is what I got. One single case in my life. This was 35-40 centimeters far from the injection point. It was not an artery, because I checked all the possible arteries. There was nothing at all. But here in this region I got this embolia cutis medicamentosa. In about 3-4 months everything went away without any remnant on the skin, because I gave her 2,000 tons of heparin, corticoids, everything, and everything went well. But that's something which may happen. On the contrary, when you inject the artery, that's another story. Because if you inject an artery, of course you can create problems, especially that may happen at the level of the popliteal fossa, at the level of the ankle, at the level of the groin, because arteries are a little bit closer to the skin, and also when you inject a perforator, as I told you before. And that's a different issue, because unfortunately the drug and the bubbles with the drug would go to the distal part of the arterial circulation, which always creates some skin, muscle, tissue loss. It is extremely rare, as I told you, but we have to keep in mind And if the patient tells you about strange pain, pull out. Strange pain, strange dysesthesia, strange symptoms. A little pain is possible, we know, but whatever is strange, don't go ahead with your injection. That's simply to tell. Here is another case, not mine, of embolia cutis medicamentosa after sclerotherapy or telangiectasia. And you see that in 5 weeks, anyway, everything goes quite well. Nerve damage, very rare, very rare. You should somehow inject the nerve or somehow disturb the nerve because of the inflammation you create in the treated vein. So perivenous inflammation, direct injection. The direct injection is more possible when you inject the safena parva because the sural nerve and the saphenous nerve are quite close. Edema, or better, lymphedema. I love to treat patients with lymphedema, so I'm quite expert, let's say, in lymphology as well, but in my experience it is rare, and when it happens the patient was probably already under a kind of lymphatic predisposition, lymphostatic predisposition. And for example, when they take calcium blockers or alpha lytics, it is more prone to develop edema because of venular dilation and overwhelming the lymphatic drainage. Now we come to the real complications finally, because all these complications were real but so rare, let's say. Matting. Matting is a problem because matting is a cosmetic problem, and if it comes after a cosmetic treatment, in Italy that's a problem. Because in Italy, I think also in Serbia, if I come to the doctor to be treated from the cosmetic side, I need a cosmetic result. And if you give a cosmetic complication, it starts to be a problem. The incidence is very strange. Again, you see probably in Europe it could be around 4 or 5% of our patients. No big difference between foam and liquid. Slightly higher with polidocanol according to Kern's study, more than STS. And why do you get matting? Sorry, just a second. Why do you get matting? We don't know. We don't know. Possibilities. Too much, too high dose, too high pressure, hormonal treatment. I give you just an example. Pauline Raymond Martimbault in Canada treats, I don't know why, a lot of transsexual men, and she gets a lot of matting because they are under hormones. So hormones could be an issue. That's why I don't like to treat patients under contraceptive pill. For this reason, for DVT, and so on and so on. So I try to stop, to discontinue contraceptive pill during sclerotherapy. This is my attitude. This is not a rule, but this is my attitude. Another possibility is not overdose, it's not over hormones, but it's just a hemodynamic obstruction. Sometimes we obstruct a drainage of a vein which is below some telangiectasia, so the skin has an obstructed drainage towards the deeper veins and gets a kind of matting in that area. That's a problem because you close the vein and you should not close more veins. So retreatment of the matting should come after some time, a few weeks, a minimum of 5-6 weeks, and very, very quiet because you don't know what's happening. Check about the hormones, check about the strange drugs that the patient is possibly taking, and so on and so on. Pigmentation is the most common complication of foam sclerotherapy and of sclerotherapy. Let's keep in mind that you all will, we all will get in a learning curve a 20 to 30% incidence of pigmentation in the first, let's say, 5 years of sclerotherapy. 20 to 30. Why? Because it depends on the technique, but also it depends on many situations which are not easy to handle. Because foam, unfortunately, can give you a little bit more pigmentation when you do not remove blood sufficiently, because the problem of pigmentation is clot retention. The more patient had clots in the veins, the higher the incidence of pigmentation. Again, which is the incidence we don't know, we should say between 10 and 30%. The good news is that in 1 to 2 years disappears in the vast majority of the cases. Do your women in Serbia wait for 1 to 2 years? No. In Italy as well, don't wait. In Italy is the same. So you have to propose some peeling, some creams, something. You have to propose something. But the best treatment is time. Talk to the patient, reassure, and explain, it will go. I would say that I prefer, more than talking, to do this. This is very important. Clot expression, clot evacuation, it will dramatically reduce the incidence of pigmentation. From Turkey, Unku, I don't know if you know him, published a very elegant study where he dramatically reduced pigmentation using clot evacuation, not only, then Villavicencio and others. So if you remove the retained coagulum, which is quite high incidence, then you dramatically reduce pigmentation after 2-3 months. So if we go to the end, it's not a huge amount of complications. As you see, this is a very reliable clinical series from GIE. And as you can see, visual disturbances are the only, let's say, relevant complication you may get. Then you may get some thromboembolic event, but it depends on the dose again, it depends on thrombophilia maybe. So following the guidelines, you may screen out those patients who are at risk, let's say. And I personally invite you to perform some thrombophilia screening whenever you are suspicious, because that would reduce probably the incidence of provoked DVT after sclerotherapy. Because thrombophilia is a little bit diffuse. If we talk about mutation MTHFR and hyperhomocystinemia, that's something quite well diffused in our area, I mean, but it's not so important. But when we talk about deficit of AT3, deficit of protein C, protein S, antiphospholipid syndrome, these are dangerous things, okay? Whatever you know, whenever you know, take care, possibly under anticoagulation, or even ask for a suggestion from a hematologist. So he will write you something and you behave accordingly. And maybe if you go to the court, you have a piece of paper, this is the hematology, this is what I did, and so on and so on. So you can find this in the document from the European guidelines. And again, the only real common are matting and residual pigmentation. These are the real complications you may get. So in conclusion, if you perform foam sclerotherapy, major complications are quite rare, although they may be significant. It's important the technique to produce and inject foam, general precautions and compliance with post-treatment instructions, because patients must collaborate. That's why I give them a couple of papers explaining exactly what to do, what not to do. And then using lower volumes, you may reduce the rate of thromboembolic and gas. So the sun always shines on foam sclerotherapy, but handle the sun with care, let's say, okay? This is my very last slide for you today. Thank you. Questions?
Some question.
Not from here,
Can you tell us which patients you are sending for checking, for example, this embolization? How you choose?
You mean patent foramen ovale?
Yes.
Wow. Well, I would reply those patients who have strange symptoms after foam sclerotherapy. That's a silly reply. That's a silly reply. But when I get visual disturbances or when I get dizziness, which is rare, but sometimes that happens, I tell, go and check. And I 90% find a relevant PFO. But if you want to know before, again, migraine with aura, I start very cautious, you know, migraine with aura start very cautious, low volumes and maybe liquid whenever possible. And anyway, when I have a stroke, cryptogenic stroke, when I have a strange, you know, patients who tell you about mental degeneration at 50 years of age. That's strange. Is it a kind of continuous passage? Not so many occasions to screen for that PFO before foam sclerotherapy. And neurologists do not collaborate so much, I would say. I send to neurologists, they say, I don't know what I should do. Think about something else because they have some visual disturbances. But anyway, I would say TIA strokes and visual disturbances with aura, with the migraine.
And one last question for me. And which screening for thrombophilia?
Post-thrombotic syndrome, always, nearly always. Because I do believe that there are provoked thrombosis, okay, trauma, okay, but many of my patients don't know why they had thrombosis, DVT, femoral popliteal thrombosis. Why? I don't know. I want to know before treating you and getting another DVT and pulmonary embolism if you have a protein C deficit, you know. So post-thrombotic syndrome, always I try to understand. And then family. My father, my mother had a DVT, pulmonary embolism, you know, whenever I talk to the patient. So a relevant history, a post-thrombotic syndrome, I try to understand more. And again, cryptogenic stroke, it could be strange pulmonary embolism in the past, I mean, a strange situation. So anything strange which is maybe linked to coagulation, I try to make the blood test. If the blood test gives you, let's say, heterozygosis MTHFR, well, that's not a problem. If it gives you homozygosis or with homocystinemia, let's say 17, 20, or if it is factor V Leiden heterozygosis, I'm quite quiet. Any other thing, I start to think more. So homozygosis, factor V, 83, protein C, S, phospholipid, these are much more complicated issues. And also very early, for example, very early peripheral arterial obliterating disease, vasculitis, thrombophilia again, so all this stuff makes me think about something strange.
Any questions? More?
Any questions? If you have the patient Berger disease, you prefer to travel to insufficiency with one?
Well, Berger disease in Italy is very rare. When I got two in my life, not more, well, detected, let's say, because maybe they have a, well, that's a vasculitis, you know, that's a kind of possible autoimmunity disease and could be related to side effects after foam. So I want to know more, and probably if I perform foam, I would use low molecular weight heparin as prophylaxis, probably. Because there are cases when I use low molecular weight prophylaxis, not so many, but that could be the case, okay? And again, if there is a peripheral arterial obliterating disease, why should I treat him? If it is for cosmesis, I'm not so happy. If it is for an ulceration with big varicose veins, okay, that's interesting to do. So it depends on the indication. Because maybe the saphenous vein could be used one day for the bypass because there's a Berger, let's say. So in general, I don't like to treat people with vasculitis because, you know, vasculitis is associated very often with thrombophilia a little bit. So Berger is, let's say, a compromise to find.